Hello, everyone, and thank you for joining us today for our webinar on Bartonella for Clinicians, Unraveling a Clinical Dilemma. To make it easier, we have muted everyone. If you have any questions, please type them into the Q&A box, and we will answer them at the end of the webinar. Our webinar today will be presented by Dr. Joseph Burrascano. Dr. Burrascano is a well-recognized specialist in the diagnosis and treatment of Bartonella and associated complex infectious diseases and the chronic illnesses that accompany them. With over 35 years of experience and research in this field, he has appeared in and on virtually every form of media, both in the U.S. and abroad. He has testified before the U.S. Senate and Armed Services Joint Subcommittee and at various governors' consulates. He is also a founding member of ILADS and ILADS Educational Foundation. After the presentation, we will start the Q&A session. During this time, Dr. Jyotsna Shah will be joining us. Dr. Shah is the President and Clinical Laboratory Director of IGeneX. She has over 40 years of research experience, mostly in the development of diagnostic tools for infectious diseases. She has authored multiple publications and holds more than 20 patents. Now, I will pass it to Dr. Burrascano.
Well, good evening and afternoon, everybody, depending on, I guess, your time zone. I'm happy to be here to help walk you through the puzzle that happens to be Bartonella. On your screen, you'll see the outline I prepared. I first want to just talk about, in general, co-infections to get us started. Then specifically, we'll talk about the biology of Bartonella so you understand a little bit about this bug, the clinical features that are commonly seen, and some uncommon things. Laboratory diagnosis there are a lot of new things that we need to talk about. Then comes treatment, which is all difficult, as you know, because there's no one regimen that is better than any one other. And the idea for me is to give you the background so you can choose what might be best for your patient, depending on the situation. Then we have the Q&A, where hopefully we can answer your questions. So those of you who've heard me speak before probably have seen a slide like this. I think of ticks as nature's dirty needle. Think about it. It's a bug. It lives in the dirt for 2 years or more. It can drink the blood from a whole variety of wild and domestic animals. And to think it has just one infection in it that it can transmit is kind of ridiculous. Obviously, if you took a needle and stuck it in the dirt and rolled it around for 2 years and poked it into fox and raccoons and deer and birds and reptiles, then injected it into a person, of course you'd think about a mixed infection. Now, the dilemma is that, as most of you know, at least in my experience anyway, nearly every single chronic Lyme patient is co-infected. And that could be the reason for treatment failures. You may be having a co-infection that you didn't recognize and therefore hasn't been treated. What we find in general is that co-infected people tend to be more ill and more treatment resistant. And clinically, their symptoms overlap so much that it's very difficult at times to be certain what's really going on. Traditionally, the test sensitivity for co-infections, including and especially Bartonella, has been kind of low, which is, I guess, the point of tonight's speech, or one of them anyway, is to tell you about what's new. The treatment regimens are very difficult because each co-infection may require different medications, so that if you have a co-infected patient, sometimes it's difficult to know which of the many different medications you can and should use. Diagnosis and treatment is difficult. Knowing when to stop also is very difficult. So let's get started. With Bartonella, we know that there are at least 30 species, probably even more. And the other thing we know is that patients can harbor more than one species. So you can have a Bartonella co-infection. We know that Bartonella can be transmitted a number of different ways. Tick surveys done in the Northeast, and actually published on the survey in New Jersey, have shown that more ticks there had Bartonella than even Lyme Borrelia. Now, the other problem is if you go to textbooks and look up Bartonella, you hear or read about cat scratch disease. And if you read about that, clinically, it doesn't look anything like our Lyme co-infected patients who have Bartonella. In fact, in my experience, the presentation that we see of Bartonella is actually more similar to tularemia. And interestingly, the germs, tularemia germs and Bartonella germs, kind of exist on a similar spectrum, so it's not a surprise to me that a lot of the symptoms and clinical features overlap. The Bartonella diagnosis is difficult. A lot of the symptoms are not specific. Some things are, but most of them are not. Traditional testing, as a lot of you know, is really not so great. When it comes to treatment, it's hard because these Bartonella germs can thrive in the blood itself, in tissues, and within cells, and finding an antibiotic that gets to all these places, it's hard. They rapidly can develop antibiotic resistance, and I can show a couple of references on that. And there's also no one single best antibiotic. They can be found definitely in biopsies, both of the skin and in the GI tract. I'll show you something on that. They're known to induce states of autoimmunity with a lot of self-antibodies. And because of the difficulty in treatment, a lot of the skilled clinicians have come up with some pretty reasonably good complementary regimens that we find is helpful to add to your armamentarium of treatment. So clinical picture, the most important thing to think about is that the CNS, the brain and nervous system symptoms, are out of proportion to the physical ones. And they seem to reflect an overactivity or an overstimulation of the brain. The patients are irritable, they have anxiety. People who never had anxiety attacks before can start to have them. Rage attacks, some really antisocial behavior, seizures and pseudo-seizures, very difficult to treat, insomnia as well. It's almost like a drug addict who's withdrawing or an alcoholic who hadn't had drink in a long time. And seeing Lyme and tick-borne disease patients who have very bad antisocial behavior is a clue. If you treat your Lyme patients and the physical symptoms are starting to improve, the headaches will last and the joint pains will last and they're more functional, but they're still anxious and having trouble in that regard, then you have to think Bartonella. I'm going to show you some pictures of the skin manifestations that are peculiar to Bartonella. And in fact, when you biopsy the rashes that I'll show you, not only can you find Bartonella in the tissues, but Borrelia seem to be there as well. One of the things that makes another clue for Bartonella is that they tend to localize in the GI tract. They can mimic H. pylori, and they also can cause a mesenteric adenitis, causing diffuse mid-abdominal pain, which is very nonspecific, obviously, and kind of confusing. And it's funny because years ago, before we knew about this, I'd treat some Lyme patients with antibiotics and expect their GI tract to get very bad, and a lot of them, the GI symptoms which were bad got better on antibiotics. It was like a crazy puzzle until we realized that the tick-borne diseases, including Bartonella, can end up in the GI tract. Because the Bartonella tend to localize in the skin and specifically the dermis, very often the patients will display tender skin nodules, especially on the lateral thighs and extensive surfaces of the upper arms. And often they have sore soles, such that in the morning when they first wake up and first start walking, they're limping around a bit because their feet hurt, and little by little that clears as the day goes on. If you were to monitor their temperatures during the day, unlike Lyme Borrelia where you find low-grade afternoon fevers, these patients are more likely to have an elevated temperature in the 99.5 range early in the morning. There can be some very light night sweats, certainly nothing as severe as you see with babesiosis, but certainly more than you do see with Borrelia. Another thing to look for is if you have a Lyme patient, you treat them, the Lyme symptoms improve, but the CNS, as I said, doesn't improve as well as you expected. That's a sign it could be Bartonella. And one final thing, if you're treating Lyme Borrelia and people are getting better and they're not completely over it, but for whatever reason you stop treatment, you find that the symptoms of Lyme in a Lyme patient take several weeks to start to come back because of the 4-week regeneration cycle and the slow growth of Borrelia. That's not the case with Bartonella. They come back within a few days. So if you have a patient who's been on antibiotics and you stop and they say, gee, within 4 or 5 days I really feel sick again, they really can't be Borrelia because they take much too long to recover, much more than the 5 days. So that's another clue. Here's some of the rashes. These are the red bumps that can scab, that can be tender, they can bleed. These things look like stretch marks. If you talk to Dr. Mozignani and the others who are experts in the field, they don't like to use that term because it's misleading. They call them tracts, T-R-A-C-T-S. They resemble stretch marks only superficially. One thing is that they're red, which stretch marks are not. Second thing is they do not follow skin planes, as you can very clearly see in this one example. And these are the things that when biopsied will show Bartonella in the dermis, and often you see Borrelia as well. Another interesting thing, I had been taught that Bartonella will infect the blood vessels, the endothelial lining, and so forth. When you look at these biopsies carefully with a confocal microscope and vital stains, you actually find that they're much more prevalent in the dermis itself and not so much around the blood vessels. So that's something kind of new. Under the arm, there's some more, and not only are they not following skin planes, but they're not straight. They have the kind of a corkscrew, curlicue appearance that you would not expect if this were simple stretch marks. On the back, you know, this looks like somebody leaned against a garden chair or something. And I had a patient who looked very much like that. And this is another one where both linear and papular rashes are present in the same patient. Let me talk to you about what has been published about GI infections. Here's a study published by Marty Freed. He took 81 pediatric patients and biopsied them in the stomach, duodenum, and or colon, and did PCR on them. 33% didn't show any sign of positivity on PCR, but of the rest, they found 1, 2, or even 3 different concurrent GI infections at the same time. And here are the details. Of the 30 patients that had a single infection, 12 of the 30 had Bartonella, 9 had H. pylori. So here, Bartonella is even more prevalent than H. pylori. He also found Mycoplasma fermentans, Borrelia burgdorferi as well. Double infections could be any mixture of the two, Bartonella and Mycoplasma, Bartonella and burgdorferi, and so forth. And some even had 3 at a time. So it's important to think about the GI tract and look for the clue like they find less GI symptoms with antibiotics. So here we go. Out of the 81 patients evaluated, 35 had Bartonella, 24 had Mycoplasma, 14 had H. pylori, and 13 had Borrelia burgdorferi. Interestingly, in every single one of these patients, the standard serology was negative. No other GI abnormalities showed up on stool examinations, sonograms, and so forth. But regarding the serology, this was published in 2004, and serology then only was basically something simple like an IFA, which I believe this was, and also they only tested for Bartonella hensleyi, and now we know with all these different species that it's very possible the patient could be infected with a different species and never show up in this type of IFA test. Speaking of testing, as I mentioned, traditional serologies, if you get it from a commercial lab like like Quest LabCorp, you're going to find that they're really testing for hensleyi only. And before we go deeply into testing, I want to just give you a little perspective. As a lot of you know, people with chronic Lyme have immune deficiencies, either as a result of being so sick, or maybe they had this before and that's why they got so sick. But serologies rely on a positive B-cell response and strong B-cell response. And many of these people don't have it because they're so sick and they're so immune deficient. So what I suggest you do in the beginning is assess B-cell function simply by measuring quantitative serum immunoglobulins and IgG subclasses. And if you find someone is B-cell deficient, decreased immunoglobulin levels, then you're going to think that serologies may be less sensitive in these people, and you want to look for more direct tests like PCR and FISH. And it turns out that there's a reciprocal relationship between serologies and the direct tests. In other words, those who are less likely to be seropositive are more likely to be PCR or FISH positive, and vice versa. So when you start to see a number of different tests being offered, and you start to say, which one should I do, think about how the person's immune response is behaving, and that can help guide you into a better testing method. Now, the new tests that are now available for Bartonella, and available through IGeneX especially, are down below. First of all, to replace the pretty poorly reacting IFA, they have a multi-species Western blot, which looks for not just hensleyi, but a number of others, and I'll show you a slide on that in a moment. They have the FISH test, made famous, of course, by the Babesia work, but now they can do this for Bartonella. And the beauty of this is that, number one, it's a direct test, and number two, it's genus specific, so they can pick up a number of different species. The PCR has been around for a while. It's very, very good. I'll show you details on that. They also have now an ELISpot, which is a T-cell test. They call it the IGeneX IGX spot. And interestingly, if you think about it, you can now test B-cell function with a Western blot and T-cell function with the IGeneX IGX spot. So it gives you kind of a picture of the person's overall immune response, which really is very important to know in terms of their treatment. So we'll talk about the Western blot. You know, in preparing for this, I talked to researchers and I found out an interesting fact. You know, Bartonella samples are used to make serologies, and usually bacterial samples are needed to make Western blots as well. And it's been found that some of the commercially supplied Bartonella samples really were not good. They had mixed species or were not very potent and so forth. So I asked IGeneX about this, and what I found is that they'll take clinical specimens of Bartonella from patients' own blood, They'll grow them on a plate, find the individual colonies, they'll pick them, extract the DNA, and sequence the DNA to completely confirm the species. Then what they'll do is they'll grow the Bartonella in culture from these confirmed colonies, and that's what they use to prepare the Western blots. So number one, it's not some vague lab strain, and number two, it's not some potentially contaminated or poorly responding commercial sample. This is actually real human infection of Bartonella. So I think that's really pretty cool. So what's the clinical result? Well, as I'll show you, the Western blot is far more sensitive than the IFAs, and it should be really the primary diagnostic test. It's got a broader multi-species coverage. For example, it covers Hensley, Quintana, Vinsonii, Elizabethae, and if it's reactive, IGeneX will report the species they detected if they can. Some are just non-specifically positive, but those that they can speciate, they will report that. And being that it is a Western blot, the turnaround time is pretty good, only 5 days, 5 working days. So how about accuracy? Well, if you take a test panel, when you do, for example, test validation, and you compare it to known positives and known negatives, the Western blot showed it was comparable 97% of the time when it comes to sensitivity and 100% of the time when it comes to specificity. So what about clinical samples? Well, let's say you take a large group of patients who appear to have tick-borne diseases. You're not sure exactly which ones they have, and you test them for Bartonella using both the IFA or the Western blot. This slide shows the result. The positivity rate of this random group of 600 Lyme patients or tick-borne disease patients, 4% of them were positive by IFA on Western blot. By IgM IFA and 4% on IgG IFA. Yet 17% on the Western blot panel by IgM. In other words, more than 4 times more sensitive in IgM than an IFA. And for IgG, it was 23%, up from 4. So that's like almost 6 times more sensitive. Now, again, it doesn't mean only 23% of Bartonella patients are picked up. These are 23% of people who are sick, and because now we know we were picking up 97% of them, it probably means 23 or maybe at most 24 of these patients really, in fact, did have Bartonella, and you'd miss so many of them if you only relied on the IFA. So the FISH test is a fluorescent in situ hybridization assay, and it's actually a direct slide where the blood is put out on a blood smear and it's stained, but instead of using typical blood stains like, Giemsa stains or H&E, they use a fluorescently labeled RNA label for the Bartonella. And what it does is it makes the smear 100 times more sensitive than a standard Babesia smear. Again, it's genus specific. So we're talking about Hensley, Quintana, Vinsonii, Elizabethae, Grahamii, and Burrascano, which are really the big ones that you're looking for. And that's why I know Dr. Shah said she likes her FISH test. Now, because it's a direct test, you want to consider using this in very early disease before the antibody response has matured, and also in any situation where the immune response is poor, such as very, very late disease or people multiply co-infected and very ill. Also those who might have had prior immunosuppressives and rendered them less likely to make a positive antibody test. Now they did some studies, and I have them listed here. In terms of specificity, there's absolutely no false positives when they tested against the 2 different major Babesia, Borrelia, Plasmodium, Trypanosomes, Anaplasma, Ehrlichia, Rickettsia, and so forth. Not a single false positive against that panel. And when they looked for inclusivity, again, these are the different species they were able to pick up: Vinsonii, Hensley, Quintana, Grahamii, Elizabethae, and then some other species which haven't even been identified yet, but they know they are Bartonella based on the sequencing that was done. Some great pictures. Everybody likes pictures. This is what the fish looks like on cultured Bartonella. You see it's a fluorescent labeled stain, so it really stands out. And the positives you really see are positive, and the negatives really negative. I'm going to show you another picture. Here's Bartonella samples actually from blood, from patients. And the top 3 are those that are positive. And again, you can see it pretty clearly. On the bottom is a negative. A negative is a negative, a positive is a positive. Very easy to see. The PCR, likewise, is a good direct test. It's genus-specific. Therefore, again, you get the number of different species. It's a direct test, so it's not affected by immune deficiencies, immune suppressive treatments, and so forth. And don't forget, for PCR, you can do this on spinal fluids as well as blood. And again, it's a good time to use this is when you think someone is expected to have a poor B-cell response. And again, in the beginning, measure that B-cell response by immunoglobulin levels, and you know right away whether you think you should do this or not. And that brings us to the last testing method I want to talk about today, and that's the IGeneX spot. The method is based on T-cell response, unlike serologies, which are B-cell, and it detects the production of interferon gamma from the T-cells that have been previously sensitized to Bartonella. Another genus-specific test that does pick up a number of different species. It's also an interesting thing that T-cell responses occur much more soon than the B-cell response. So again, early in an infection, before the antibody response is detectable, the T-cell response can be found to be positive. Now, because they're independent totally of serological results, you can use the IGeneX spot, not just in early disease, but again in those late cases and those with poor immune function. As I mentioned earlier, it's neat to use these as tools to assess the integrity of your patient's immune response, because if you can do a Western blot, which is a B-cell test, and an IGeneX spot, which is a T-cell test, and then maybe one of the direct tests like a FISH, you get a really good picture. If someone is FISH positive and B-cell negative, Western blot negative, there's an immune response issue going on, and that's something that has to be separately addressed. Now, because there's no one test that's 100% perfect for this, what's done basically in our practice is we kind of use a panel approach. As I mentioned, you're going to try B cells, T cells, and a direct test or two. And this again shows it. 130 patients who had tick-borne diseases, not necessarily all of them having Bartonella, but just sick patients. The most sensitive was the Western blot, which, as I said, is why it's the primary test, replacing the IFA. But there are some that were positive on FISH that were not positive on Western blot, some positive on the T-cell spot response test, the IGeneX spot, and not positive on the others. But by combining them and doing a panel approach, you picked up 53% of patients, more than any one test alone. So again, we learned this long ago with Babesia. Same thing with Bartonella. You need to do more than one test. I made a little summary slide here. The IFA, as I said, first thing on the top, it's only the one species, not very sensitive, not very specific, and really it's been replaced by the Western blot, which has a high sensitivity on proficiency testing. It does do multi-species, primary test, rapid turnaround time. The FISH test is an old favorite. Its limit of detection is 10,000 cells per ml, which is actually really pretty good, much, much better, 100 times better than a standard blood smear. Again, very early and very late disease, people who are seronegative, immune deficient, these are the ones who you want to do the direct testing on, like the FISH and also the PCR. Again, the PCR is multi-species, highly sensitive. Limit of detection is only between 100 and 1,000 cells per ml of blood, so that's really very good. And then the T-cell test, the IGeneX spot, good sensitivity, very high specificity, and as an add-on, it really helps give you a picture of the immune response. Now we're going to talk about treatment. This is probably going to confuse you, and if it does, that's because it is confusing. So I want to give you as much information as I can and tell you how I came up with this, so you can get an idea of what might be working, what might not be working, and help you design a good regimen. Because Bartonella is in the cells and in the bloodstream and in the tissues, you have to kind of think of using combination treatment, just like with Lyme, Borrelia. There are different species, as I said, we know of at least 30, and some of them have different antibiotic susceptibilities than others. And since it can be co-infected with more than one species, again, you might have to consider a complex regimen using more than one antibiotic. Now, when you look at drug studies, they're confusing. And I started to look at it. I was looking at these panels of MICs and MBCs, and some of the tests, some of the articles showed, wow, plain old amoxicillin or penicillin has a 99% chance of killing it off based on what blood levels you can do. And we all know that doesn't work. And I saw this again and again and again in the studies. And then I realized what they were doing is they were doing these studies in vitro. They weren't accounting for the fact that this is a bug that can be inside cells and inside tissues and be absolutely not represented by the kind of testing they were doing. There were very few articles that actually were in vivo testing, either in tissue cultures or animal studies. And those are the ones I relied on more, number one, because it makes sense, and number two, it seemed to match the clinical experience I've had in treating these infections. Some of the veterinarians have thrown up their hands and said, well, I don't think we can even cure this stupid infection. A stupid infection tonight's a medical term. But, veterinarians have not been using multiple drugs. They've been using single agents. Now, here's a quote from some of the literature. Turns out that there's an RNA mutation that is the most frequent substitution found in clinical isolates. And what is it? It's a mutation that confers erythromycin resistance. And of the erythromycins, azithromycin is the one most likely to be most resistant. Clarithromycin, which is by accident, is a little bit more effective than azithromycin is, yet they had been using azithromycin in their clients. Some of them were veterinarians, some of them are human doctors, and they were saying, gee, this is why these azithromycin failures are occurring. You look at fluoroquinolones, and they work really very well, but over time, as you subculture these in the lab, they start to develop treatment resistance. So fluoroquinolones can be used in the regimens, but not, again, as a single agent. So, again, you want to combine drugs. Let's go through the list. Cell wall drugs, such as the penicillin cephalosporins, and even first-generation cephalosporins are really very effective for these because they're bactericidal to the Bartonella. Bartonella do contain beta-lactamases, so you do want to use a lactamase-resistant cell wall drug. But the problem is they only work, as you know, in the intravascular space. They're not so great in tissues, and they don't get into the cells really effectively. So that could be part of the regimen. In other words, if you have a Lyme patient on a cell wall drug, like ceftriaxone, Ceftin with cefuroxime, that would be a good foundation to start, because any Bartonella that escapes from inside of a cell will get knocked for this, because it's really a good bactericidal drug when the bug is where the drug is. So again, it's an interesting choice, but that one drug is not going to do it. If you look at literature on treating cat scratch disease, they talk about using Keflex for 10 days. Well, obviously, it's not going to work for our patients. As I mentioned, fluoroquinolones have shown extremely good results in actual in vivo testing with animals and cell cultures, but over time, drug resistance can occur. So that makes it kind of tough, because it's a very, very good drug for killing the bugs, but it can't be used as a single agent. Now, that's not also considering that fluoroquinolones can be toxic in some patients, causing tendon problems and even CNS irritability. It's a whole separate discussion, but there are tricks that you can use to maybe get around that. What about the macrolides? As I mentioned from that article, rapid development of resistance when it's used as a single agent. It's got genetics for this. It means that even before you put the patients on this, they already have Bartonella, that genetically they're just not going to respond to it. And if you have someone on azithromycin, it'll kill what can be killed, and the other ones will grow out, and you got the infection. So azithro as a single agent is not such a great idea. Now, rifampin is very popular, and it's a good idea because it's very widely distributed into the CNS, tissues, and so forth. But remember, it's only bacteriostatic. It's not bactericidal. So that might be another foundation drug, but don't expect that alone to work. Also note that it does induce cytochromes, not only causing potential drug interactions, but even hormone deficiencies, especially the steroid hormones, which is not good when you have a weak, sick patient. And this is one of my favorite quotes from good old Ed Breitschwart. He doesn't like tetracyclines as a single agent. He says, this is the quote, "You cannot float a cat, dog, horse, or human in enough doxycycline to eliminate Bartonella." And I visualize him with a giant bathtub dipping his patients in this, but that's besides the point. Now, if you look at the literature, especially on treating endocarditis from Bartonella, the drug of choice, believe it or not, is gentamicin. Here's a quote: patients receiving aminoglycoside were more likely to fully recover with a P of 0.02. Those treated with aminoglycosides for at least 14 days are more likely to survive the nose on shorter therapy duration. And always consider this for treating Bartonella endocarditis. Now, the drawbacks: it does not penetrate the central nervous system, and it can be toxic, especially when you combine it with a macrolide. You have to worry about kidneys and ear toxicity. But again, gentamicin and the drugs in this family can be monitored by doing blood levels, and if you keep within recommended parameters, I've used this a lot and I haven't seen any problems, knock on wood, so I don't think you should be afraid of it. Now, you're not going to have someone on long-term gentamicin, obviously, but it is something that can be given to patients who are really sick. All right. What about treatment duration? Again, from literature, they found that if the treatment duration is less than 15 days, relapses are common. And they recommend treatment for 3 to 4 months. And here's the reference on the bottom of the slide. So that kind of fits with what we've seen clinically. I just kind of on my own through experience found you really need a good 4 months of effective treatment to get the Bartonella controlled and not have it come back. So it's nice to see literature and my experience kind of overlap. So some options. For example, you can use a lactamase-resistant cell wall drug to get the circulating Bartonella, and a fluoroquinolone, which is really great as long as you're not having toxicity issues. So, for example, Augmentin and Levaquin. Another example, cell wall plus an intracellular ribosomal agent like ceftriaxone plus Biaxin. A common combination for treating Lyme disease does cover Bartonella to some degree as well. Two ribosomal agents together, if at least one gets into intravascular space, would be a good idea. And again, here we have Doxy plus Biaxin. I know Rich Horowitz likes this combination, and it does make a lot of sense. Here, Doxy does work, or at least is helpful, because you have the Biaxin to back it up. You could add a ribosomal agent and rifampin. Common combination of Biaxin and rifampin is great because Biaxin induces cytochromes, rifampin inhibits them, and the two together tend to balance people out a little bit better. I've even had patients on triple drug regimens and have included gentamicin for the more severe cases. And so this is kind of information I want you to have to know what works and what doesn't and why, so you can come up with a combination regimen, especially for co-infected patients that might need more than one drug for more than one infection. Now, the complementary treatments are interesting because there's actually literature on this. Number one are transfer factors. A number of different vitamin supplement companies market these. And there's published data on effectiveness for immune support and also in treating and preventing autoimmunity induced by these infections. They stimulate production of new helper T cells, killer cells, macrophages, and cytotoxic T cells, according to the literature. So if you have someone who you know has Bartonella, but the IGeneX spot, the T cell test, is not reactive or weakly reactive, then this is an obvious thing to add to the regimen to help bring that along. And again, the quote there, it works in multiple opposing functions of biofeedback to help control immune overreactions, autoimmunity, and so forth. And there's a reference on that. Arginine, good old-fashioned, inexpensive, cheap arginine amino acid. It prevents the activation of drug resistance genes and also moderates TNF. And there are the quotes. It counteracts the detrimental effects induced by TNF in Bartonella infections, and they did microarray analysis on the genetics of Bartonella. And what this does is it returned the genes that were activated in Bartonella infection back to a steady state when they were induced, when they were given sustained doses of arginine. So if you can add arginine, if you have someone who's not prone to herpes virus, you can add arginine, and it might really help the patients get better. If someone is at risk for getting herpes virus reactivation, of course, you can always add lysine and others. But this is an interesting, simple thing that may really help. Other complementary therapies, because Bartonella is such a tough infection on the body, you always want to do some work on the mitochondria to do what I call mitochondrial rescue. Always add NT factor and other membrane building factors. You want to work on the metabolism by adding B-complex, CoQ10. NADH has been found to be helpful in this situation, or lipoic acid, of course. And methylation support. Some of the smarter people that I've learned from have told me that even though someone might have normal methylation genetics, the stress of the illness, if you want to use such a simple term, will cause methylation problems, and they always recommend methylation support without worrying about the genetics. In fact, a lot of them stop doing genetic testing for this. They just give the support anyway. The antimicrobials that have history of being helpful, one is acai, which is a very simple thing you can get in most any grocery store. And specific companies, specific formulations, for example, Research Nutritionals makes a line of supplements that have clinical clinical studies to back them up. There's a broad experience of supplements from Beyond Balance and Byron White that have had positive effects on these patients. And, they don't have literature on it to support it because of some technicalities of the FDA, but there's enough experience out there that these things can be helpful. So the conclusions. Diagnosing Bartonella can be difficult, as you probably all know. That's why you're on the line. And so you really have to have a high index of suspicion, know what to look for in the patients, and then do a panel approach to testing, but not just throw every test at them, but think about what test might work best in their situation. The treatment is not straightforward. You might be treating more than one Bartonella species at a time. You really do need a combination of antibiotics. And recurrences and relapses are common, and you just have to retreat or find a different regimen. But the good news is that you can treat Bartonella and the other co-infections concurrently because there is an overlap of a lot of the medications. And as I just showed you, there's a documented, proven role for some of the complementary therapies. And that is the end of the formal session. What we're going to do is be joined now by Dr. Shah. Dr. Shah, are there, say hello. And we're going to open up this for Q&A.
Great. Thanks, Dr. Burrascano. That was excellent. So yeah, now we have some time for some Q&A. If you have any questions, you can enter them in the Q&A box. It's either at the top of your screen or the bottom of your screen. And it looks like we have a few already. One here is, when should I use Western blots versus IGeneX spot and fish tests?
Well, let's have Dr. Shah answer that one.
First of all, thank you very much, Dr. Burrascano. It was great talk that you presented. I'm sure everybody enjoyed it and learned a lot about Bartonella, because I get questions from a lot of physicians and practitioners about Bartonella treatments, and this would be a great session. Hopefully it's been a great session for them. Now, when it comes to testing, as Dr. Burrascano had shown, that different tests work at different times. What we recommend, based on what we know today, is a lot of times physicians don't know what state their patients are in terms of the disease. Is it early disease, late disease? So we recommend doing Western blots first. It kind of gives you a baseline. If that test comes back negative and you need more to find out what's going on, I would say IgE spot works well, or PCR. And FISH, of course, is a great test in patients where you're suspecting the disease. I would highly recommend that test. So a panel approach to me seems the best approach for Bartonella when you do not know the status of the disease in the patient.
I'm looking at the list of questions, and I see one person has asked about the striae or the tracts. You're not supposed to use the word striae anymore, but the tracts are tingly. And if so, why? Well, yeah, I've seen that. And now the biopsies that we've seen, this research going on at University of Minnesota, they find that the very same areas of skin that have the infection of the Bartonella and the dermis are areas of the skin that have damage to the small cutaneous nerves, both myelinated and unmyelinated nerves. And this is studies that I've been working on now with several different neurologists, and we're actually going to work on getting a lab together that can do the biopsies for you to look for the nerve damage. So yeah, we've seen that, and it makes sense because you have an infection in the dermis affecting all the tissues there, the blood vessels as well as the nerves, and the blood vessels that feed the nerves. So yeah, it's very common.
Second question, can fish testing with LabCorp Quest be trusted? I don't think they can do the Bartonella fish test. We are the only ones that offers Bartonella fish test at this point in time.
So question about rifabutin. I know that rifabutin is being used more and more now because it is more effective. It's basically a more effective version of rifampin. And yes, if you're going to use that class of drug, then that is the drug of choice. But again, it is bacteriostatic, so it's only one of many that should be added together, one of several that should be added together for a sicker patient. All right, let's see. Pamela, question about low VEGF. What I found years ago, before I even knew what Bartonella was, they called it Bartonella-like organism, BLO. It's my favorite, my famous BLO lectures. Knew there was something out there that was Bartonella-like or tularemia-like, and before we knew it, all was going on. And a subset of these patients had elevation of VEGF. Well, VEGF is induced by some species of Bartonella, but not all. So if it's elevated, it's useful to help you track therapy. If it's elevated in the beginning and therapy is working, the levels go down. If the level's already low, it doesn't help you at all. So it's an elevated level that's good. The low levels do not.
You want to? There's a bunch of questions. Dr. Shah, you want to?
How does it? Regarding how does the testing compare with Galaxy Labs? Okay, Galaxy Labs looks at culture, so they put their samples to culture first before they look at it at different time points. They do an IFA test and they do PCR. Whereas we look at Western blots, and we are finding with this that our test is very, very sensitive. We are looking at 4 species. And in my opinion, Western blots are far superior than IFA tests. PCR, from what I understand, is not the most sensitive test. Even in at Galaxy Labs, their IFA test is more sensitive. So the methods we use is different. The big difference is we provide an answer in 5 days with one sample, whereas with Galaxy Labs, with what they are doing currently, you need to give 3 samples and it can take up to a month to get an answer. But they're good. They're very good too.
And then you get to talk to Ed Breitschmidt. He's a favorite guy of mine. Question about biofilm busters. Boy, you're asking the wrong person because, you know, I could ask that same question because I don't know. We know that biofilms are very important in not just Borrelia, but also Bartonella now. And the same skin biopsy studies have shown the dermis being the target. You can actually see biofilms associated with Bartonella in the skin and also in the bloodstream. And this is really very interesting. Not published. It's very early work that I saw when I toured some labs. But now the question is, what about biofilm busters? And, you know, I guess I don't have a good answer for you because I'm very skeptical. You know, a biofilm buster is an enzyme, right? It's supposed to break up the biofilm by enzymatic digestion and so forth. Well, how much of that is actually going to get to where it's got to go? I mean, you have to swallow it. It gets mixed with saliva, then gets digested. It meets your stomach acid, intestinal enzymes. Then it has to get to the GI tract, the lower GI tract, and survive the bacteria that are there, get across the membranes, survive through the immune system, go through the first pass of the liver, and get into the bloodstream. How much of the biofilm buster that the patient swallows does get all past that and into the bloodstream and into the tissues and still work? I kind of bet none of it does. But, you know, I don't have an answer to that. It's just my skepticism. And if anyone has an answer, you can tell me because I would like to know myself.
Great. Dr. Shah just ran to get a document real quick.
Okay.
He's coming back. Yeah, we still have quite a few questions. Thanks for all the feedback and the questions. We're going to try to get to everyone here before 6 o'clock. So here's Dr. Shah again. I think there was a question about New York.
New York, yep. Yeah, this one. Okay, for New York, at this point in time, we are not approved for Western blots. We haven't submitted them. So you can do, in our case, a panel that can be done by New York doctors is CP1. All the tests there are, CP5 is the panel you can do on our panel for New York State patients at this point in time. We will be working on getting approval for our Western blots. Hopefully, we'll submit that by end of September. FISH is something they're not going to allow us to do in New York. They believe PCR is far superior. And so I don't think FISH will ever be approved for Bartonella. However, for Babesia, it is approved.
Great, thanks.
I see a question about IV therapy for Bartonella. I used to use gentamicin as an add-on, and you know, gentamicin, don't forget, can be used IM. It doesn't have to always be IV. And I've had good successes with it there, but it's not something that I would put someone on routinely. It's kind of a rescue drug, a drug almost of last resort when really they have no other options in terms of not tolerating it or can't get a good response. But lately, some of the more effective complementary treatments are effective enough, at least in the experience of some, that you may not need to go to the gentamicin. But I've had patients who were losing their eyesight, for example, and you said, I'm not going to just give them some drops of herbs and hope for the best. I'm going to give them what I know works, and then you do it on the gentamicin. So that's one answer. The other answer is IV cephalosporins, again, great for Lyme, great for the intravascular Bartonella. And, you know, a lot of you have probably had the same experience as me. Before you know about Bartonella, before you think about Bartonella, you have a Lyme patient on IV antibiotics, and they're really feeling great on it. As soon as you stop, they feel bad again. You put them back on, they feel good. You stop, they feel bad again. And if they start to feel bad again within 5 days or so, by the end of the next week, again, it's something moving much more quickly than Lyme, so you have to think Bartonella. But the flip side is, when they're on the treatment, they really felt well. So you know that you have a drug, the cephalosporin IV, that really is helping them. So if you have someone on IV therapy for something else, make sure it's one that will also hit BART, and then you can use that as a foundation to add upon other treatments. So yeah, it's been used, and I do use it when necessary. So yeah, think about it. NT factor. NT factor is a supplement, non-prescription, that helps to repair the damaged mitochondrial cell membranes. And mitochondria, of course, are the metabolism center of the cells, But these steps of metabolism of, the Krebs cycle and all the other cycles in the mitochondria actually occur on a mitochondrial membrane surface. So if you have damaged membranes, no matter how much vitamin B and CoQ10 you give, it's not going to work so great until you get the membranes healed. So NT factor. I remember years ago when it first came out, my poor sister who's been a Lyme patient, I put her on that, and within a few weeks she called me and said, "What is that you gave me? I feel so much better." And I really rely on that a lot for my chronically ill patients, Lyme and Bartonella and otherwise. So I do recommend it. It's not expensive and is completely well tolerated and doesn't interfere with any other drug that I'm aware of. So I do recommend it. Now, next one I can answer. I guess Dr. Shah can too, but the question is, if someone's been off and on treatment for years, what do you use? I would use a direct test. I would go for FISH if it's available in your area. If not, then a PCR. I probably would do a T-cell test as well. The Western blot may not be positive if someone's off and on treatment a lot, although it might be helpful to see species. So I would still go for a direct test first, and that would make sense. The reason why I mentioned the T-cell, the IGeneX spot, is because the reactivity in that type of test does tend to track the germ load. So if you see that done on a serial basis, someone's sicker, the level is higher, someone's feeling better, the level is lower, which is unlike serologies. So that's a semi-quantitative test in the experience of a lot of people. So I would do that too.
And I just want to point out that the difference between the Bartonella IG export that we offer and the ones which are offered by other labs is that we have developed the test to look at multi-species of Bartonella, we don't just use one fragment to determine whether Bartonella is there or not. So it's going to be very sensitive to detect different species of Bartonella.
I see a question from Pamela asking, where do I look this up? There is no book. It takes 20, 30 years of experience to trying to at least think about a question, let alone answer it. So no, you're going to have to go to lectures. I believe that this webinar is going to be available online somewhere. They'll tell you at the end of it. So it's something you can go back to and listen to again, or maybe take notes. But this is all based on clinical experience. You have to go to the meetings, talk to the Lyme docs, and actually get some expertise by just doing it with your patients. You learn from your patients, you always do, and just keep notes.
Webinar about babesia, testing and treatments. I think that would require a full seminar to discuss babesia. The approach for any tick-borne disease from a diagnostic point of view to get the best answer where you do not know the status of the disease is a panel approach. That would be the best way to look at any disease based on our experience here.
There's a question about a European company, Makewell. I've not had any experience with that product, so I'm sorry I can't help you with that. So you'll have to ask somebody else, sorry. I'm sort of in the woods with what I know, and that's already a lot of guesswork. Christopher asked about gentamicin. Well, the doses are pretty standard. I think it's 1 milligram per kilogram every 8 hours, whether it be IV or IM. And you have to measure peak and trough levels and keep adjusting every few days based on what the levels show. As I said, you can do it IV or IM. It does hurt a little bit IM, but not so bad that you have to worry about, giving Novocaine with it or something like that, lidocaine mixed in like you do with ceftriaxone. So it can be done either way. I think a patient, after getting a dose every 8 hours, after 10 or 12 days, is going to tell you if they want to stop. But I have used it, and it does work really nicely, surprisingly well. And Hope is asking, which are ribosomal drugs? Those are the ones that are the tetracycline family, like tetracycline, doxycycline, minocycline, as well as the macrolide family. That's azithromycin, erythromycin, clarithromycin, Baxin. Those are all the ones that work against the ribosomes. Gentamicin does work against ribosomes, but a different ribosome, which is, again, an interesting reason why they're mixed. But as I cautioned in the body of the lecture, gentamicin has some known side effects. One is ototoxicity and one is renal toxicity if the levels are too high. But that's the same kind of pattern of toxicity you see in the erythromycin family drugs. So I tend not to mix the two together, but you certainly can use gentamicin plus one of the tetracyclines like doxy or minocycline. So that would make sense because it's a different ribosome, but they're both ribosomal agents. So that's a little clue for you right there.
Okay, how did we choose a species? For the current, we decided on the species that we are offering right now. This is based on clinical information that we gained by looking at patients, uh, and by sequence information, we knew which species we should look for. This was based on our fish studies. So our fish essay was the one which led us to start thinking about more than one species, and all the work that came from Brensville's labs, talking about different Bartonella species. That lab, his work has really moved Bartonella a long way as to what we should look at. So all the information which is out there from their lab and what we found clinically in our patients made us decide what we should test for.
So in other words, you found a positive fish, and you actually took those very bacteria and tested them with DNA sequencing to find out what the heck they were. And to your surprise, they found a lot of different species.
Yes.
Yep. I see a question about immune deficiency. As I sort of alluded to when I was talking about that in the body of the lecture, there's some patients who have decreased IgG levels, IgG, IgM, IgA, the levels are low. And the question is, what came first? Were they immune deficient, and that's why they got so terribly sick when they got bitten by the tick? Or did the tick-borne infections cause the immune deficiency? Well, we know that tick-borne infections can do that, but we also know that if you have a weakened constitution, you're going to be hit harder no matter what infection you get. So to relate that clinically, I've had patients in whom I found this, and I treated the tick-borne disease, and it all went away. And I found others where I treated them, and it didn't go away. So I guess we do have a mixed population of all these patients. And the bottom line is, get them on a reasonably good course of treatment, and hopefully you're covering all the different important infections, and they're following your good, healthy lifestyle hints and so forth. And you follow their levels. If after a few months, the immunoglobulin levels, which do fluctuate, you have to get more than one sample. If those are not recovering, then you have to consider getting them on IVIG or at least sub-QI immunoglobulins to help support that. But it's very hard to get insurance coverage. You have to really document that they need it. Now, this is a little clinical trick. Insurance companies want two things. They want, number one, low levels of immunoglobulin, and you obviously will have that. That's why you're asking the question. Second thing is they want proof that they have recurrent infections or infections that won't clear up. Well, I use PCR, and I said, look, this is a person who's been on antibiotics, in some cases IV, for month after month after month, and after treatment, they're still PCR positive. So obviously their immune system is shot. This is the kind of drug, if you believe IDSA, should have cured them in 3 or 4 weeks, and they're not cured, so they need IVIG, and it got me covered. Of course, they're talking more about people with chronic recurrent sinus and pulmonary infections, but it does work when you talk about tick-borne disease. It's one more reason why I like the fact that nowadays with Bartonella you can do PCR and you can do fish, because you can say, look, the germ is still there. I see it with my own eyes under the microscope, at the fish test. So a little clinical pearl back there. Another question about treatment. Drugs such as Bactrim and Septic, can that be used for Bartonella? I know it's being used clinically. The studies that I've read about it were not terribly convincing, but in terms of, in vitro, so forth, and there was nothing in vivo that I could find on using that for Bartonella treatment. However, in my clinical trials, when I first found about this BLO, Bartonella-like organisms, I found that as one of several mixed drug combinations, it can help. Can help a little bit. I didn't list it in my slides as one of the choices because just my personal bias, that's not as good as you had hoped it would be, and there are other choices out there.
Dr. Shah, you want to?
I'll deal with the when fish and when PCR. In our hands, we find that PCR in real patients, in patients is more sensitive than PCR, because with PCR, you have to process the sample and then do PCR on it. So every step, you're going to lose some part of it. And with fish, you are not doing anything. You're taking the sample and staining with RNA probes, and we find that to be very, very sensitive. We've shown that with malaria, with Babesia and Bartonella, that fish is very sensitive. So our recommendation is to do fish as the first choice, PCR as second choice.
Question comes up about using the complementary treatments such as Beyond Balance, Byron White, and so forth. The question is, do these formulas actually kill the organism, or do they support the host to tolerate the infection without clearing infection, or do these actually clear the infection? And no one's been able to do a study that convinces anyone either way, but I do know that patients improve on it. And my approach has been to use the antibiotics that we have documentation will work for the people, and then we'd either blend in the complementary therapies that you list, or what we'll do, we'll use the antibiotic get a real good head start, and then stop the antibiotic, and then continue the treatment with Beyond Balance. Byron White is effective, but very hard to tolerate. I think Beyond Balance is a little bit better tolerated and just as effective. So it's just my personal bias from what experience I've had, which isn't a lot, but it is some experience. But I see that very commonly, that people will use the antibiotics to get started and then do a gradual switch over to the complementary treatments as well. But don't forget the arginine, the transfer factors, and the mitochondrial support, because that will help a lot, and you can do that concurrently with the antibiotics. Dr. Shah, I see there's a question about a general blood test. Are there any markers that you should be used as a precursor before deciding on advanced testing? Have you found any markers that help you decide what to do next?
That's very difficult. Sometimes we might see that, in Lyme and TBRF, we might see some bands which suggest that it's not really Lyme when it's Lyme negative. So we would recommend doing TBRF, but I don't have any good answer for that.
TBRF being tick-borne relapsing fever. See, laboratory people talk in jargon.
Sorry, thank you.
Doctors to translate. Sorry about that. I see a question about disulfiram. Great question. Disulfiram, for those of you who don't know, Ken Lignard published a really remarkable study on showing how disulfiram helped patients who were co-infected with Lyme and Babesia. So the question came up about Bartonella, and I spoke to several different clinicians fairly recently about this, and a lot of them are trying it. I don't have an answer yet. Some suspect it will help a lot. Others don't know, just don't know. So it's too early for me to give you an answer, but I know people who are good people are looking into it. So just stay tuned.
Great. So it looks like we're coming up on the top of the hour. There's still quite a few questions left, but Dr. Shah and Dr. Burrascano, maybe we can just sort of go through them and cherry pick a couple, and the rest we'll have to answer after the call. That's okay.
Well, a quick question, autoimmune encephalopathy, that's something you get a positive Cunningham panel. That's someone who really needs immune modulator therapy, IVIG being the drug of choice. Also transfer factors, obviously alpha-lipoic acid, and possibly gabapentin, or GABA, just the non-prescription supplement. It all depends on the symptom complex, but that's a place to get started. But you really do need immune modulators, and hopefully not steroids. And now, Dr. Shah, about chronically positive Lyme, IgM.
That's an interesting question. The answer here is that if you're just going by the IgM bands, I don't know the answer. But if you had PCR and that was positive, that would clearly show that it's an active infection. Whether it's a new infection, I don't know. But active infection, that is why we always recommend that in patients where we don't know the stage of the disease, that you should really do immunoblots and PCR. Because if PCR and IgM is positive, for sure that it is an active infection.
And the immunoblot does not give you the false positive IgMs that you get with the Western blot or an IFA. So that's, again, why the immunoblot is important.
Yes, we are finding that the specificity of immunoblot is greater than 98% for IgM as well, and IgG. It's really it's a great advance in terms of specificity and also in terms of sensitivity. So we are not seeing false positives from viruses or other Borrelias on Lyme immunoblots.
I guess the last question is the question of the night: is there any proof that you've cleared your Lyme and Bartonella infections? And we don't have a test for cure. Stay tuned to IGeneX when they get the culture out, which is my favorite treatment, of course, or my favorite test. But no, right now we don't have a test for cure. It's all clinical.
Great. Well, thanks again, Dr. Burrascano and Dr. Shah. And thanks to everyone who could join us today. Really appreciate it, especially those on the East Coast. I know it's late now. As a reminder, a link to this recording will be sent to you within 24 hours, and you can view it at your leisure. And also, the questions that were not answered will be answered probably within 48 hours because they're all stored here on the back end, and we'll get to them as soon as we can. Thanks again, and have a great evening.
Thank you all.
If anybody has any testing questions, feel free to contact us and we'll try to help you out.
Thank you all and good night.
Good night.
Good night.